Hello, this is Jeff Caney again. I have another case to share with you. This was a 50-year-old male who presented with some acute onset neurologic changes and was admitted for further evaluation. As part of the workup, a CT scan of the chest was done looking for occult malignancy. And as we look through the chest, we'll see that there's this complex-looking left pleural collection with at least some loculations and tracking to the fissure. But as I go down, you'll notice there's some nodules here that are higher attenuation than the background fluid. You can see multiple ones here in the pleural space. We see some underlying atelectasis of the lower lobe and a few more of these high attenuation nodules. And note this is a non-contrast, so these are dense as blood pool, if not a little bit denser. And in the upper abdomen here, we see these multiple high attenuation soft tissue masses that have similar density. On the abdominal CT that followed the chest CT, we now have IV contrast, and we consider that these homogeneously enhanced during the portal venous phase, and these are typical of splenules. Turns out this patient had a history remotely of splenectomy for an unknown reason, but we can see that these implants in the pleural space are indeed enhancing along the same attenuation that we see with the upper abdomen. So this is a nice example of pleural splenosis. Most commonly, this results from trauma with splenic rupture and seeding of the pleura. It can happen with diaphragmatic injury, but doesn't always occur. Even small injuries are enough for the splenic tissue to implant. And it usually will follow the other splenic tissue on different phases of contrast. The easiest way to prove this, if there's any question, is to do a sulfur colloid nuclear medicine study. You can also do a damaged red blood cell scan, anything that is taken up in the reticuloendothelial system. But given the history and the CT findings, it was deemed not necessary to do any further evaluation. This can be important for a couple of reasons. First, we want to not mistaken this for a malignancy, but also if the patient is having complications related to hypersplenism, that this residual splenic tissue can be contributing to the problem, even though the spleen itself has been removed.